Okay, so let's start. So, distinguished guests, esteemed participants, ladies and gentlemen, I'm Vincent Zhong, Associate Professor of the Jockey Club School of Public Health and Primary Care at CUHK. As the MC of tonight, I welcome you to the second webinar of the five implementation science seminar to be held in these 2 weeks. And today's moderator is Professor Pierre Nilsen. Implementation science, often referred to the science of getting research into practice, focuses on bridging the gap between evidence-based intervention and their successful integration into real-world setting. It is a multidisciplinary field that draws upon various disciplines, including public health, psychology, sociology, management, and many more. At the second seminar of the series, we'll focus on the practicalities of doing implementation science research. Throughout the next 2.5 hours, we will have the privilege of hearing from 3 renowned experts in the field who will share their invaluable insights and experiences with us. So the first lecture will be delivered by Professor Yeoh on implementation mapping, a tool to inform policy design and implementation strategies. And the second lecture will be taught by Professor Jeanette Wassar Kirk on the co-creation challenges in implementation science. And finally, we have Dr. Jeanette Wassar on the topic of bridging implementation science research and practice. We hope that this seminar will provide a platform for knowledge exchange among participants and our experts, and encourage you to all actively engage in the sessions, ask thought-provoking questions, or share your own experiences or perspective. Please type the questions or your thoughts at the chat box, and I will share it to the speakers for response. Since we only have limited Q&A time, we won't be able to select all the questions to response. So without further ado, let me introduce the first speaker, Professor Yeoh. He's the director of the Center for Health System and Policy Research at our school and co-director of the CUHK Institute of Health Equity. His research is in health systems, services, and policy, with an interest in applying system thinking in studying how the complex components of health system interact and interrelate to improve health. He also supports the work in health system of Western Pacific region of WHO, undertaking commissioned research, and has completed consultancy reports on governance and hospital planning. Professor Yeoh was Secretary for Health and Welfare and Food of the government of the Hong Kong SAR government between 1999 and 2004. From 1990 to 1999, Professor Yeoh was the head and first chief executive of the Hong Kong Hospital Authority. Now I will pass the time to Professor Yeoh. Professor Yeoh, please.
Thank you, Vincent, very much. I'll try and share my screen, and if I can't, then perhaps you could do it.
Yeah, Jenny can help you.
Yeah.
Okay.
All right, so I managed. Anyway, this is I think we all had a very useful session yesterday. Professor Pierre Nilsen gave a very good coverage of the different determinants and the different approaches in implementation science. And of course, it's a complex subject. So what I thought I'd do today is to talk about one of the projects that we are funded from, where we're using implementation mapping, right, to look at a policy that government is planning to implement. So the outline is talk about implementation mapping, and then demonstrated by the study of development of implementation strategies for the policy of direct access to physiotherapists in primary care. And I'll cover these in my talk. So implementation mapping is a tool which can be used to inform policy design and implementation strategies. It's based on two things, based on first, a protocol to develop and design multi-level health promotion interventions and implementation strategies. So implementation mapping started off with intervention mapping, where people developed it for health promotion. But when they did that, they found that the implementation component was inadequate. So they used the same tool to develop the implementation issues, where it's, as you know, Professor Nilsen talked about implementation being the science of methods to increase adoption and implementation and maintenance of evidence-based practices, programs, policies, and guidelines. So implementation science and intervention mapping is the basis for implementation mapping, which I'm going to talk today. And I'll clarify some of these terms because it can be quite confusing. So when you translate interventions into practice, there's the 6 steps. One is, of course, intervention mapping. So when you're developing multi-level implementation, so the audience that are involved in health promotion, you really need to design the intervention. So you have 6 steps. You have a needs assessment, change objectives, select theory-based interventions, integrate into organized program, and then plan adoption, implementation, and sustainment program, and then an evaluation plan to conduct, in fact, and process evaluations. So in fact, this was the original intervention mapping, right, for health promotion. But they found that the implementation component that they developed there was inadequate, and now it's being informed by implementation science. So what we're looking at today is number 5. So that's expanded into implementation mapping. So there are 5 steps of it, and I'll cover them one by one. So in implementation map logic model, what you have is that the first three steps, as you see, are the ones that are being developed for the intervention. But then when they start looking at the implementation mapping, you start off by the 3 tasks to identify the adopters, the implementers, look at the performance objectives, the terms of adoption, the contextual phrases. So you can see that it's a planning process that goes backwards in terms of the steps, because the idea being that when you're planning an intervention, you should also be planning the implementation. So the task that we talk about is not planning the intervention, but planning the implementation. So implementation strategies are methods or techniques used to improve adoption, implementation, sustainability, scale up of interventions, including small-scale strategies to influence specific determinants of a task, overall package of strategies to influence adoption, implementation, managed behaviors that will ultimately determine whether a program is adopted, used, and maintained over time. Right? So the translation intervention into practice. So I give you one example in the literature of a program, so-called Peace of Mind program. So the Peace of Mind program is an intervention to support and scale up mammography uptakes. So this is an evidence-based program which has been evaluated. So it's the evidence programs to intervene so that people will continue to come up for mammography. So the task in terms of implementation mapping is to identify, because they are really the programs are evidence-based, so they're not looking at the intervention itself, but the adoption of the intervention. So the first task is to identify the adopters and implemented by the roles, then look at the performance objectives, the implementation outcomes and determinants you want to look at. Then you design the implementation strategies, and then look at the produce implementation protocols, evaluate processes and outcomes. Right? So that's giving you the background. So today, what I'm going to cover is the development of implementation strategies for this policy that the Hong Kong government is contemplating of providing direct access to physiotherapists in primary care. I know that for some of the audience in your countries, this is already a policy, but this is not so in many Asian jurisdictions. So this is a project which I'm leading, and we have a number of co-investigators who have people in physiotherapy, we have nurses, we also have researchers that are helping us. So the background is direct access to healthcare professionals, self-referral. Patients are able to refer themselves to a therapist without having to see anyone else or without being told to refer by a health professional. So obviously the benefit is cost-effective, leading to fewer visits than physicians, greater function improvement, greater efficiency of care, better clinical outcomes. But there are some concerns, because for some of you who may not be familiar with the health system, in most health systems, or in some health systems, the doctors refer patients to other professionals. So in Hong Kong and in some countries in Asia, the physiotherapists cannot see a patient directly. They need to be referred from a physician, right? Because there are concerns of the the physiotherapist's competence in medical screening and differential diagnosis. So they're worried that the physiotherapist may not be good at making a diagnosis, so they may be treating the patient for a wrong condition. And there's also concern about potential de-skilling of physicians in musculoskeletal diagnosis and manage. Now, of course, the third concern is the economic concerns that doctors are concerned that patients will go to physiotherapists themselves. So when you look at, this is from the World Physiotherapy Association, it obviously advocates direct access to physiotherapists for better outcomes. Direct access is permitted in many countries, UK, US, Australia, New Zealand, Singapore, Thailand, in Sweden, but it's permitted only in the private sector in some countries, in Denmark, in France, Italy, Macau, Indonesia, but it's not allowed in Hong Kong, in Japan, in Korea. Right? So Hong Kong has started to look at this, and this government in 2021 said they were looking at possible legislative amendments to enhance the role of the allied health professions in primary care by permitting patients direct access. And in the next year, government said that they felt that there should be better multidisciplinary health services, and they were intending, or they are intending, to amend the legislation to facilitate direct access to service by physiotherapists and occupational therapists without a referral. So, government has been looking at this policy, but the physiotherapist board, in Hong Kong, the medical profession, the health professionals, there's a supplementary medical profession board, medical professions that oversees the regulation of all allied health professions. And within that supplementary medical professions council, there's a board that governs physiotherapists. So the board itself had a working group to look at how it could implement this referral system for physiotherapists. They looked at the conditions. So they looked at in their proposed model of direct access, they set conditions. So it's not everyone. So the settings that they're looking at is primary care health setting, because after all, we're looking at primary care. So in secondary and tertiary care, which is more specialized, those are not covered in their proposals. So they say that these would be any setting where you provide primary care. But they also looked at the conditions, the types of patients that should be referred. So this is their proposal. But this is not necessarily the proposal that the government is going to implement, but this is the starting point. This is what they're saying should be done. And of course, being the professional body, government would obviously pay attention to their views because they are the regulatory body. So for patients who do not have a pre-existing medical diagnosis, they require the patient to give written consent, which when the patient comes to you, it's already consenting. But anyway, they want a written consent. To refer the patient to a medical practitioner if the symptoms and signs are beyond the practice scope of physiotherapy practice. This is quite rational and probably doesn't need to be in, but of course they need to restrict it. With a pre-existing medical diagnosis. So these are patients who already have a diagnosis. So these are patients who already have a diagnosis of back pain due to degeneration by a doctor. So there's no restriction to the duration of number of visits to physiotherapy because that's already a diagnosis. But they require that the progress and discharge summary should be uploaded to the electronic health system and should be available upon request. So upon request, obviously, of the patient and with consent of the patient to a referring doctor. Right? But if the patient does not have a pre-existing medical diagnosis, so if the patient doesn't have a diagnosis of degenerative back disease but has back pain, the patient can be seen directly by the physiotherapy if he or she feels that it's within his or her scope of practice. But however, they set a limit. They say a medical referral is required when the intervention needs to be continued for after 30 days or 30 days or 10 visits, whichever occurs first. And if the medical referral is required for any recurrent condition within 6 months from discharge. So if the patient had a back pain and then another 6 months had back pain, then you require referral. So these are conditions set for the direct access model for physiotherapy in Hong Kong being proposed. But they also have additional requirements. They require the physiotherapists to have completed a special training program. The program is going to be provided, so it will be accredited by the Physiotherapy Board. So presumably this will be in terms of diagnosis of primary care problems, and then when to refer on and looking at identifying for complications. But they haven't specified. But they also require that even so they don't permit new graduates to go into this program. So the minimum clinical experience is 2,000 hours of clinical experience to qualify to go into the special training program. And this is about approximately, I calculated, about 1 to 2 years after graduation from physiotherapy. The insurance says that there's not a problem. The risk is equivalent to current practice, so unlikely to increase. But they also require mandatory continued professional development. So these are the conditions set for direct physiotherapy access. So we're using this as a starting point. So objectives of our program is to examine the policy design, including the initial scope of practice and conditions for direct access, of what is permitted and not permitted, in what settings, taking reference to the literature and country experiences. This was the proposal that we produced before the Physiotherapy Board's proposal, because this research proposal was submitted a year ago. And to assess relevant stakeholder views on direct access, identify barriers and facilities for implementation, then identify the implementation strategy and actions needed to implement direct access, and determines of implementation using implementation mapping, informed by implementing science methods, and verified by a Delphi survey. Right? So I already mentioned about the 3 tasks. Right? The first task is looking at the implementation needs assessment and identify adopters and implementers by role. So this is the implementation mapping task. There are 3 tasks. The second is to identify the outcomes and match performance to excellent determinants. And the third is to select of design and implementation strategies. So for the first task, we are looking at the literature review and qualitative in-depth interviews to understand policy design, facilitation and implementation and barriers, identify adopters and implementers to collate their views and perspectives of the policy design. So I'll take this one by one. So the first method in terms of the 3 tasks, in terms of methodology for the first task, we're starting with the literature review. I said we were collecting the experiences of other countries. We're looking at case studies from UK, Australia, Singapore, look at relevant documents for local context, articles from international agencies such as WHO and the World Physiotherapy Association. And we are then looking at the key informant interviews. We are going to do an interview of the policymakers and implementers, because remember we talk about the implementers and the adopters. So we will be interviewing the government policy bureau in charge of health in Hong Kong, and the Department of Health, who is the operational arm of the government in terms of carrying out the legal requirements. The physiotherapist boards, because they are going to be responsible for the implementing the program. The Supplementary Medical Professions Council, under which the board works. The Hong Kong Medical Council, that's the council for doctors, because they will also be involved in the adoption. The physiotherapy and medical associations, provider organizations, they may be group practices or private hospitals, insurance, tertiary education programs, because they'll be offering physiotherapy programs. And we'll also be looking at the adopters, key patient groups. We'll also be then doing focus groups of the adopters, post-discharge from hospitals in the community, a mix of discharged patients and community patients. So we look at patients because they'll be adopters. We also look at the so-called implementers and adopters, because very often the implementers may also be adopters because they may be individuals in private practice from the public and private sectors. And then we'll be also looking at the referrals from medical doctors, from inpatient settings, outpatients. So we'll be doing a very comprehensive interviews and focus groups of the policymakers, implementers, adopters, and the key stakeholders. So that's the first task. Right? Those are the adopters and implementers and what their concerns may be. Then task 2 and 3 would be for deliberation consensus on the policy design. So for the components of direct access, the groups constitution is required, and then using the IRM with reference to the ERIC taxonomy to identify from the focus group and among the stakeholders in terms of what the implementation strategies that we will be deciding. So the first part is identifying the implementers and the adopters, the barriers and facilitators. Then we'll be looking at how this can be addressed in developing the implementation strategies. And finally, this will then be fed to a group of experts in the Delphi. And in terms of through this process, we will also have an expert group that will be helping us look at design the implementation strategies before it goes to the final Delphi. So we'll be using the consolidated framework for implementation research, which Professor Nilsen talked about yesterday, looking at the intervention characteristics. The important would be here the adaptability, because adaptability, because the physiotherapist board itself has set up conditions for the intervention. So we find that maybe the adaptability might be a key part. So we'll be looking at that in the context of when we're choosing the designs. We're also looking at the inner setting, that's the structural, political, cultural context where implementation will take place, the implementation climate, and the outer setting, we'll be looking at the patient's needs and resources, right? So because in this framework, patients are seen to be in the outer setting. Yeah. We will be also looking at the characters of individuals in terms of at the stage of change, which is the adopters and implementers. And then in the process of implementation, the process of change and engaging the key individuals to get on the board with this implementation. Right? So in the next task, we'll be looking at developing the implementation strategies using matrices with reference to the expert recommendation for implementation change, the ERIC taxonomy, and then implementing strategies presented in implementation research model, implementation research logic model, and verified with Delphi. So this is the third step of the implementation mapping. Right? So the ERIC recommendations for implementation changes, I think you mentioned yesterday, looks at the different factors that we will be looking at in terms of implementing changes. So we can look at the change infrastructure, the financial strategies, supporting clinicians, interactive assistance, developing stakeholder relationships, adapt entailing context, train and educate stakeholders, the use evaluative release strategies, engage consumers. So these are all the factors that we'll be looking at, and we'll be deciding which are the ones that will be useful for change. But in particular, we think that adapt and tailor to context might be important. So in Hong Kong, obviously, the proposals are already being tailored to the context of Hong Kong's environment by the Physiotherapist Board. But when we do our stakeholder interviews to look at barriers to facilitators, adaptability of the guidelines, I think will be very important. So we'll be specifically paying attention to this, so that when we plan the implementation strategy, we may find that there will be certain conditions where it will be facilitate the implementation, where the objections from the doctors may be addressed. Right? So when you look at the implementation research logic model, so this was quite useful because in order for us really to look at what strategies are using, we'll be looking at the construct of the determinants, look at implementation strategies which we have derived from ERIC, and then looking at the mechanisms of change and then the outcomes. Of course, yesterday you heard about implementation outcomes, service outcomes, and clinical outcomes. So obviously, for our object, our main concern is implementation outcomes. So I think yesterday you already heard that even if you have a very good program, you might not get the ideal clinical outcomes if your implementation outcomes are not satisfactory, because it's really the implementation, which is one component affecting the effectiveness of the intervention. So having gone through that process, normally most of the literature would be then they end up here, because through the whole process is really through the literature review, through the interviews and surveys interviews and focus groups, then also informed by analysis of these using these frameworks, and advised by an expert group. But we thought that for this program, it might be important to have another layer to look at the validity of our recommendations. So we're going to finalize it by having a Delphi group. So this a group, a method for structuring a group communication, so the process is effective in allowing a group of individuals as a whole to deal with a complex problem. Of course, this is a complex problem. So we have done a lot of the synthesis. The synthesis has been looked at, and with the input of expert groups. But we feel that another larger group might be useful where they're able to deliberate the concerns. So we'll be setting up an expert panel of 10 experts. We'll have physiotherapists, we'll have patients, we'll have doctors, and other healthcare-related professions and provider organizations. So in the first meeting, there'll be deliberation to brief the expert panels on the purpose, the different conditions, the criteria for different access, so the whole process. So the recommendations for implementation will be presented, and the background and the rationale will be presented to the panel. And then we will first ask them to comment on the components, identify any critical gaps in the component strategies, and suggest amendments. Then we'll construct the final questionnaire based on the results of their input. Then after that, we'll be doing a rating, which will be face-to-face or Zoom meeting, to rate the Delphi questionnaire and the criteria of the policy design implementation strategies, and provide comments for those where a consensus is not reached. So the rating will be on validity, feasibility, and clarity. Right? So there'll be a 5-point Likert scale on whether they think that the recommended strategy is valid, whether it's feasible, and whether it's clear. And we will only have a positive, we will consider that it's a positive consensus if 75% of the experts rate the 3 statements at least a 4 or a 5. For ratings below 3, and comments and suggestions will be made by experts, revisions will be made for re-rating. The rating itself will be anonymous, because the Delphi process is where the rating is independent, so that people can have different dissenting opinions and do not face pressure from peers. So the rating itself is anonymous, right? So it's done anonymously. So we then have the step 3 might be a second round of rating for the statements that have not reached a consensus, either validity, feasibility, or clarity. And if a positive consensus is still not reached for any specific question, another round of rating may be further arranged. So those in the final report, those that fail a positive consensus will be dropped. So the finalized conditions for and criteria and implementation strategies for direct access will be developed. So I think this is the last slide. I'll be happy to clarify any questions, because it's a complex study.
Should I or Vincent?
Yeah, so if there's any questions, you may type in the chat box. So maybe while we are waiting for questions from the audience, why don't you start raising some questions for Professor Yeoh, please?
Yes, thank you, Professor Yeoh. I think this is a highly complex, multifaceted project, which you really use a structured, comprehensive approach method. So I think it shows I guess the challenge of implementation, that there are so many stakeholders and multifaceted. So it would be interesting to hear if there are questions on this, also from Jeanette and Julia. If you have any thoughts.
Yes, happy. It will be Jeanette and Julia. It'd be quite useful if you give any of your critique. It'd be helpful for us, because I think we're all because these are complex things, and we're using different frameworks and for our study. We certainly appreciate any comments that you may have.
Hi, this is Julia.
Hi, Julia.
I loved seeing this, and actually I feel like your presentation will set up the things I'm going to talk about very, very nicely in a little bit. And what I think I loved the most is that you were able to incorporate so many different frameworks, because I think many people find that it is hard to bring in, for example, implementation mapping, and the CFR, the Consolidated Framework for Implementation Research, and the ERIC strategies, and pulling them all together. Because I know, hearing from people who are doing implementation studies and implementation practice, it's pulling all the pieces together that has been very, very challenging. So I really appreciated that.
Oh, thank you. I look forward to listening to your presentation. But this is a very challenging, complex field, very important, particularly for policies. Right? And so I think the clinical programs are relatively straightforward, where they're well defined. But in yesterday, I think there was some discussion. I think Professor Nilsen already mentioned about the methodology using observation studies. In fact, it's more challenging to do an observational study than to do a randomized trial or clinical trial, because there's so many different variables, and even deciding which ones that are going to pay particular attention to. And I think also I find that probably there needs to be some. I think most people find that there needs to be some iterative process, because as we go through the as we do our interviews and focus groups, things might emerge, and then we might need to really deal with those.
I also think your project shows the maybe I shouldn't call it power struggles, but the sort of different professions, potential tensions. And I think, Jeanette, some of your research has shown similar, and actually amongst different physicians in your project on a new emergency care department. And I think we usually are not so good at capturing those tensions in implementation science, but they are probably quite valid many times. Any thoughts on that, Jeanette?
Yeah, thank you for a nice presentation, a very impressive work you have done and are still doing. Yeah, I was wondering, could you tell us a little bit about your thoughts about bringing in users and participants? As Per said, you have many different types of users and professions. In your research group, have you discussed, or what has been the most challenging about inviting different types of participants or users in your project?
Yes, I think that's one of the key things that we're looking at, because we have physiotherapists and physiotherapists, and then some of them are trained in Hong Kong, some are trained elsewhere, so they have very different perspectives. Some work in the private sector, and many work in the public sector. And in the private sector, they may be in group practices, or they may be in individual practice, or they may be employed by a private organization, provider. So there are all these different areas, and then also on the other side, the doctors. So the doctors, there are a whole range of different views, because not just in terms of the background, but some doctors are truly concerned. So I think that's the area that I think we'll be looking at. Some doctors will be, because we were discussing ourselves, some doctors will be concerned about safety, and there may be a genuine concern. But my answer to that is that even if the doctors themselves, I mean, not all of them can make an adequate diagnosis. Even primary care doctors may not refer on to appropriate to a specialist. So obviously, the problem is a generic one, but of course, it's the culture as well, what has gone before. So people are traditionally more comfortable with the status quo. So they're not comfortable when things change because they know where the problems are. So it may not necessarily be a professional problem. It's just a practice problem. But there are some also who generally dead against whatever you're going to say. They'll say no, right? And of course, there are also economic concerns as well, right? So see, we're trying to look at all these different stakeholders. So so we try to cover them in both the interviews and the focus groups, right? So we'll be able to try to generate more of these inputs, and the focus will be quite useful to try to distill out some of these issues. Of course, we also have patients. So we bring patients groups in, they represent the patients, but you also bring individual patients. So we're looking at the different types of patients, the older ones, the younger ones, patients with the disease, patients who are well. So we get a different perspective. So we're trying to cover all those.
That's interesting. Do you train your research staff among doing these types of facilitations, or
yes,
or what do you do?
No. Our staff are used to doing this, so they've been trained. So we do a lot of these focus groups and interviews, because my area of work is in policy. So we've been doing these the qualitative type of work, and then we also have done a number of Delphis as well. So we're quite experienced doing this. Okay. So the Delphi conduct is also quite important, and recently, because we also look at the group Delphi process, the usefulness of that, where people can interact, but also in the rating process, it must be anonymous.
Okay, thank you very much. I think we need to go on, and I think it ties in with the.
Yeah.
Or do we have any questions from the audience?
So far, I don't see any. So maybe we can now move on to the next presentation. So thank you very much, Professor Yeoh, for the excellent presentation. Up next, we have a presentation from Professor Jeanette Kirk. She is Associate Professor at the National Institute of Public Health, University of Southern Denmark. She's working on developing methods that can ensure that evidence-based knowledge and clinical innovations are transferred into daily clinical practice in the healthcare sector. This includes systematically screening for barriers and facilitators across multiple levels of contexts and organizations, hereby develop and apply implementation strategies that overcome these barriers and enhance the identified facilitators to increase the uptake of evidence-based knowledge and clinical innovations. She's using ethnography, field studies, and cultural analysis, which form the basis of analysis for her understanding of the local culture and context. She's currently the principal investigator in several research programs where she works with user engagement for the development of context-specific interventions and implementation plans. So now, Jeanette, let me pass the time to you now. Okay.
Yeah.
Share
Thank
screen.
you. Yeah, I will try to share my presentation with you. Yes. And maybe we should start with the beginning instead.
Yeah, we can see your slides.
That's great. Here? Is it okay now?
Yes, okay.
Okay, first of all, thank you for inviting me to talk with you today. I will talk a little bit about user involvement or user engagement. As Vincent mentioned, my name is Jeanette. I'm originally trained as a nurse, and I work in clinical practice for several years. Later on, I finished a master's degree in nursing, and in 2016, I defended my PhD. which focusing on the importance of culture for the implementation of screening and guidelines in healthcare. My expertise with user involvement or engagement comes from 11 years as a development consultant and as a daily manager in a simulation unit where I've worked with involvement of users in relation to education and learning activities. Knowledge and tools I have brought into my research project where I've worked with user involvement. And one example is from my PhD project where I conducted a co-design process involving various types of healthcare professionals from different sectors. Since I completing my PhD, I have worked with several research projects in collaboration with peer, which focusing on implementation, including one project, the first one, the Walk Copenhagen project, with a long-term user involvement component. This also means that I draw from the healthcare sector, but the key factors I will address today apply broadly, whether you're working within the political, the social, or the educational context, you can use them. So what I'm trying to cover today in the proposed lecture is how stakeholders and end users are involved or engaged in the development of both intervention and implementation, and the challenges that are associated with it. I will talk a little bit about workshop as a method for involving or engaging users and stakeholders. And the learning objectives are what is user involvement or engagement, and I will return to the switch, and how to develop a strategy to ensure involvement or engagement of users and relevant stakeholders from practice in the development of neither or an intervention or the implementation. So what I will try to cover in the lecture is why user involvement, the definition of terms, how to involve users, what is user involvement, something we have defined as an involvement mindset. I will talk about planning co-design processes and introduce the workshop as a method for you. Maybe if I have the time, I will give you an empirical examples, and then we're going to reflect a little bit about concept and pros of user involvement. But starting from the beginning, why user involvement, and what do you understand by user involvement? I would think it could be very nice if we will chat a little bit about that. And I'm quite sure that Pierre will focusing on what you are typing in the chat, so we can return to that. But why user involvement? The argument in the healthcare sector is that our healthcare system is undergoing change, and there is a political pressure for a paradigm shift. And this is due to improved treatment, leading to organizational changes and adaptations. Pierre mentioned one of them in Denmark, which is we're changing the emergency system right now, and we have been done that for the last 10 years. And as I heard from the former presentation, the physiotherapy praxis is also going to be changed at your place. Specializations resulting in the centralization of hospitals and shorter hospital stays. Demographic changes with a rapidly growing elderly population, as well as an increased number of young people being diagnosed with a mental disorder. There is a rising complexity in treatment pathways, a lot of technological advancement. And at last, we also have the implementation science field that have shown a significant challenge in spreading, including adopting, implementing, and scaling up intervention, despite showing value in both efficacy and effectiveness studies. And this has led to a demand for interventions designs that are more clinically relevant and easier to implement. And one of these designs is the participatory designs that acknowledge user involvement. And participatory designs is defined as a process involved investigating, seeking to understand, and development and supporting mutual learning among multiple participants in a collective reflection. Participant typically takes on two main roles, as a user and as a researcher/designer, where the collaborative articulate their desired goals and collectively arrive at some solutions. And when you talk about participatory designs, you quite often talk about technological solutions. So participatory design is an approach to design it originated from design research that actually seeks to involve all stakeholders in the design process to ensure that the outcome meets their needs and are usable. So participatory designs is an approach focusing on the process and the produce of designs, but it is not a design style, you can say. So when we talk about user involvement does not have one definition, and there's no one set of measures and tools. It's a quite complex concept with multiple components. Involvement is referred to as a wicked problem, making it difficult to pinpoint clear causal mechanism and measures. But if we're going to talk about in broad terms, what is it? It's something about giving a voice to the user and thereby empowering them. In user involvement, there is a desire to address individual needs, preferences, and knowledge. And the way we're going to do this is by working with dialogue-based decision-making and program planning, and doing it systematically through the use of frameworks so that the process becomes visible and usable. If you look in the literature, then the field of user involvement has many terms that are frequently used. The movement of involving users, as Pierre and I have referred to in one of our articles, we have called it an engagement movement. In one of has resulted in a lot of different terms, unclear and sometimes inconsistent, as well as conflict in literature on how to interpret this concept. The terms that I have mentioned in the slides are the terms frequently used in the literature, but what is important for you is to remember to define how you understand the terms and where you draw them from. Because again, there are no one definition, final definitions, and no one tool to measure this kind of involvement or engagement. And when we talk about involvement or engagement, I'm quite inspired of a researcher called Dominique and her group. And she's talk about involvement means to enclose or surround, whereas engage means to come together and interlock. So simply put, you can say that involvement means making or doing something to someone, while engagement implies more doing something together with someone. And that's quite a different. So when I work with engagement or involvement, there is quite different perspectives I include, depending on my objectives for inviting someone in to work with me. Professor Dawn Stacey, inspired by another researcher, Carmen Idel, has developed this one framework for user engagement, considering various level and context. Here you can see she's working with direct care or organizational design, or the yellow bar, as I have put on the circle here, the research bar, or for example, policy making. If you look at the yellow bar, then you see that the lowest level of engagement, citizens or patients participate in focus group interviews, where their statements are used by the researchers in scientific studies. But there are no guarantees that the participant statement will have an impact. At the other end of the spectrum of this yellow bar, they themselves are participants with equal partnerships and shared leadership, involved in all parts of the research project, from developing the proposed to co-authoring an article. So it is within such a continuum that you should consider your user engagement or involvement. And there are several types of these frameworks out there in the literature like this. Again, it's important that you argue why you choose what you do and what it can help you with. We need to think about and discuss a little bit about the mindset that are necessary if you want to involve or engage someone. In this article, you can see here on the slide, we have worked a lot about developing this engagement mindset, because within research, or at least within the funding bodies, it has almost become an expectation for researchers to involve users to a greater or lesser extent in the research. But the question is, it is something that every researcher simple can do? Doesn't it require something to involve someone? For example, reflection concerning ethical issues, types of designs, degrees of involvement or engagement. And that was what we wrote about in this article based on our Walk Copenhagen project. And one approach to, or design, you can say, to engage someone is to work with co-design processes. But if you want to work with that, then you have to believe in engagement. If you want to engage and invite people in co-design processes, it's required that you believe that every people or every participant can be creative, that they can contribute with good ideas and their experiences. It also requires change in power. Per mentioned it 2 minutes ago, a power and control position. It's quite necessary to change these positions. And co-design quite often threaten existing power structure by demanding the control be changed and given to potential participants or users. This can be challenges, especially if you are normally the expert, for example, a research expert, or you're a manager. It also requires change in roles. We're talking about when you're doing that co-design processes from a more translational moderator role to a facilitator role. You can say in traditional design processes, researchers take on a transitional role between the end users and the designer. In co-design processes, the researchers take on a facilitating role. This means leading, guiding, and providing scaffolding of a blank slate to encourage people at all levels of creativity. I'm quite inspired by some design researchers, Sanders and Stappers, and you can see the red figure here on the left from my point of the slide. The figure is actually a historical figure showing the movement about engagement internationally. The figures show that the user-centered design approach, you can see on the left side, the users as subjects, has primarily been a phenomenon driven by the USA. But since the 1970s, people have gained more influence and initiatives in roles where they provide expertise and participate in information, idea generation, and conceptualization activities. And in the more earlier stage of the design. And this movement have moved from the left to the right, where the users are becoming more a partner and designs as participatory research. A more Scandinavian and European design has been approached. More research have taken into account when they are developing the co-design processes. If you look on the other side of the slide, it's another way of picture what I've just have said, that primarily it's the researcher or the designer who's asked the participant, for example, by interviews or focus group interviews about their experiences. But then it is the researcher or the designer that make all the creative thinking by putting in theories and frameworks and then developing a report or an article. And thereby the users are not so involved in the engagement and the creative thinking process. And you can see on the right side, in the co-design process, the roles are mixed up. Quite often, everybody is an expert in their own lives or the experiences we want to study. And the researcher quite often take on a role as a more facilitating part, putting in reflective questions, securing that everybody is giving a voice, and so on. So that's the historical movement, you can say. If we're working in more public health, the public health fields, then there are not a historical tradition for engaging users, but researcher has shown that engagement leads to increased patient satisfaction and a higher quality of service delivery. And therefore, it makes sense to engage users. And there are several models and frameworks that can be used in co-design processes, such as action research or participatory action research, or recently a model for a broader term called participatory health research has emerged. However, despite all these models, there was actually no systematical framework for planning co-design public health intervention and evaluating their impact. So therefore, this article I've mentioned in the bottom of the slide, Leaks et al., has developed this produce framework as a framework you can use when you want to plan co-design processes. It talks about, I would not go through all these different types of issues, but think about the problem. It's important to specify the problem, what you're actually going to study. Think about who should participate in this co-design process. You have to talk about discussing and selecting strategies for ensuring ownerships, equal contribution and influence, and sharing knowledge among members of the group. Something that we learned from our Walk Copenhagen project was, for example, should it be the researcher or the health professional who ultimately makes the final decision about the intervention component, even if there wasn't evidence of part of these co-designed components. That was actually a struggle for us as researchers because we were the expert. We know the literature and what was evidence and what was not. But some of the participants choose intervention component there were no evidence for, but we have invited them. So these types of questions you have to address and think about before going into invite or actively do this co-design process. So, yeah. This engagement movement has led to a significant focus on engagement methodologies, and there is not a hospital, a municipality, a region, or even a country who did not develop some kind of reports or research article on how to work with user involvement. And in Denmark, we have a National Knowledge and Competence Center for User Engagement in the healthcare sector, which has developed this small report. It's on Danish, unfortunately, but it is a guide that is highly recommended in Denmark to participants and clinicians in the hospital sector, but also to patient and relatives and researchers if we want to work with user engagement. But one method that are highly mentioned in many of these types of reports is workshops. The former presentation was talking about focus group interviews and maybe also single interviews, but workshop as a method is a quite used method when you want to work with engagement. And if we look at the literature, there are not so many articles that actually describe how to develop and work with workshops, but Pavlin have actually developed this small article for 10 simple rules for running interactive workshops. And a workshop here is defined as a structured set of facilitated activities for groups of participants working together to explore a problem and its solution over a specific period of time in one location. And they have actually developed 10 golden rules, which I think have been quite helpful when we have been working with workshop as a method. First of all, you think about, is workshop the right method? Sometimes it's better to get individual feedback on a project or test it with another method, such as, for example, simulation training, etc. It depends on the purpose of why you want to work with workshops. Additionally, workshops often require more time and resources to plan and conduct. You have to choose your participant carefully. For example, if they are healthcare professionals, should they work in groups with those they know? Should they work in groups with their own professions, and so on? Ultimately, the outcome may depend on your compositions in the workshop. What are the goals or purpose of the workshop? What knowledge or result do we want to achieve? and then plan the workshop's activities accordingly. There are guidelines that can help you with presenting goals and activities when working with workshops. In addition to a more overall moderator, then use facilitators if you have individual groups in the workshops. Brief them so they are clear on their purpose and the goals and so on. And the most important thing is that facilitators are impartial. They should not offer ideas or judgment, but encourage and challenge creative thinking. Their task is also to take notes. Then you have to plan the physical location, inspect the place. Is there room for the tables to be in groups? Are there whiteboards? Which one? Should poster be used? Should there be name tags, catering, etc.? Participants who sit for several hours and engage in creative thinking need something to drink and eat. Remember, budget for that. Plan for the workshop. Be as interactive as possible and as fast as possible. Let participants create something together. Flip charts with poster. Use pictures. Some participants even bring clay or yarn. These workshops are mentally demanding for both participants and moderator and facilitators. So plan breaks, stand up, and sit down. Yeah. Okay. It's also quite important to think about when you want to invite people in a workshop, then you can use the workshop as a networking thing. For example, send out the participant list to everyone before when you send out the invitation. Then they have the opportunity to go through the list and think about if they know someone, or afterwards if they want to connect with someone. Get the best out of the participants. Let them introduce themselves. If you want creative thinking, then stimulate it. Give individual group creative names, for example. You can also start with something of an icebreaker. Make a small exercise where you bring people together. It's best to follow up with your facilitators right after the workshop is finished and ask them to highlight the 3 most important attributes or points that you believe the workshop had contributed with. Also ask your participants for feedback afterward. Only through this we can learn to improve. So there are other methods that are quite useful. For example, focus group interviews. But I don't go into that kind of method right now. But this is actually one example of a good article you can use if you want to plan workshops. Okay, in relation to involvement or engagement, it's also quite important to ask yourself, is the co-design process a goal in itself? Or do you want to use the co-design process only to develop, for example, an intervention? But if you want also to measure the engagement or involvement part, there are a substantial body of scientific literature that can assist you to select an outcome and methods for measuring involvement. On the left side of this slide, there are one instrument, the user engagement scale, developed by Heather et al., which is a quite used questionnaire consisting of 31 items, where the participants score their own experiences of involvement. Other studies recommend asking patients through qualitative interviews and/or having an observer present in the room during workshops, focusing on the interaction between the researcher and/or designer and participant, and thereby assessing the potential involvement. Once again, discuss the possibilities and limitations of the various method choice and provide argument for them. Okay, I think I'm in the end of my presentation, but I really want you to take a minute or two to reflect on benefits of user involvement and engagement, challenges, and what have you found most valuable for this small lecture right now? And then you put it in the chat and we can discuss it. And hopefully, Pierre, you can help me to see.
Yes.
I I can't see the chat unless I
can see the chat. I have
okay, that's
I
great.
keep track. Thank
Okay.
you very much. I think I mean it's notable. I think the increased emphasis on user involvement. We have sort of mandated in some of our funding agencies that there must be some sort of end user involvement. And I think the argument is usually here. I'm part of one of these funding agencies board, and the argument is that facilitates implementation. If people who are going to use and work with this are involved in the development process, it is more likely that what we do our research will be put to use. And I think I'm not sure I've seen so many papers on that, but that's sort of the argument.
Yeah.
And we have here a question.
Yeah.
Eliza. The difference between guided interview, for example, focus groups and individual interviews, and an interactive workshop.
Yeah. You can say that when you have semi-structured interviewed, you have structured or semi-structured. The structured are quite what do you call it? Fast form. You don't give the participant the opportunity, to talk a lot about other things than the question you ask them. Where if the interviews are more semi-structured, then you give the possibilities to go on a track. You talk about one thing, but then they're thinking on some other things, and then you move a little bit away from the main question. But that's give you an opportunity to get a more broad picture of an objective that you actually are interested in. If you're working with focus group interviews, quite often it depends on many people. Quite often is a bit confused about what is group interviews and what is focus group interviews. If you look at in the literature, then the focus group interviews, you are quite focusing on the interaction between people. So you're focusing on how people, what do you call it?
Interact.
Yeah, påvirker. Can you help me here? Yeah.
Discuss.
Change. Change attitude along the way. It depends on who's in the group and how they put on social pressure, or they listen to each other. So they quite often they change attitude when that's what you're focusing on in a focus group interview. If you have an interactive workshop, then you are actually more focusing not on how they actually is being kan du hjælpe mig, Kenneth? Påvirker på engelsk. Being change attitude regarding each other, but more about this creative thinking, how people in a room can come up with good ideas, and then a new person can go on that creative thinking, building on something, or maybe take a discussion and then move in another directions. So they're more focusing on what you're going to develop than actually on the persons who is sitting in the group, you can say. But again, as I mentioned, it's quite important how people are placed in interactive workshops, because they can put on pressure on each other. And if you're inviting people who are not so creative thinking, then they're not giving so much to your process. And it requires much more work for the facilitator to people to open up and give their voice to the product that you're going to develop. So I think there is a difference, because where are your focus? Did that answer your question?
Is a question also follow up? Is focus group not considered the platform as co-design with patients?
Yeah, it is. It is another method that you can use when you co-design something. quite often in focus group interviews, you have not a designer with you. So it depends on where co-design processes actually comes from the design literature, where you want to develop, for example, a new technological tool or something like that. And it's come from different traditions, you can say, but focus group you can use with patients to co-design something. But it's quite important that you use the focus group to really give your participant a voice, give the patient the voice, and not only use it as a tool for where you can call it cognitive involvement, where you have listened to people and say thank you for your time, and then you do what you feel most right or what the evidence show you as a research group. It's really important to be honestly inviting and listen to people's and the patient's voice.
Would you agree? Yeah, many thanks. It's clear now. Would you agree that workshops are somewhat of a risk-taking? It's not always creative. It can be creative, but it can also be not sort of generating that much relevance. That's my impression. Yes, there's a wider span of outcome.
Yes, that's correct. And again, we have to think about it comes from the design research, where they're quite creative, and they develop and go on, and in many iterative circles, you can say. If you develop new telephone or something like that, then you move on with the users again and again and again and again. So, but we are not so familiar with that in research, and we quite often have a very specific aim we want to achieve, and if we make the focus group interview, we have a little bit more control as as researchers than we actually have in the co-design process. And if you invite the wrong people in a co-design process where they're not creative, it's really hard work.
Do we have any more questions? We could also, if questions arise, take them after Julia's presentation. What do you think, Vincent? That we
yeah. So thank you very much, Jeanette, for your interesting presentation. So now I know much more about the co-design methodology, because this is actually something quite new for me as a epidemiologist by training. Something of a very useful way to understand the perspective of the users, because if you want to implement something, eventually you want the users to be happy, you want them to uptake the intervention, right? So I think this is actually one of the key steps for conducting successful implementation research. So the last lecture for today will be delivered by Dr. Julia Yeoh. She is the Executive Director of the Center for Implementation, a social enterprise based in Canada that trains, supports, and empowers individuals and organizations in applying theory and evidence-based informed change methods to improve outcomes. She is known internationally for her ability to communicate complex intervention science concepts in a clear and actionable way. As an expert on the practical applications of implementation science, her work focuses on the spread and scale of accessible training and supporting hundreds of change initiatives around the world. She has designed and taught courses and workshops taken by over 10,000 professionals from a wide range of fields. So Julia, will you be able to share screen, or should I help you to...
She's asking to be made a co-host.
Yeah, Jenny, can you help? Okay, let me try. Just a moment, and we will need to find Julia from the room.
Wonderful.
Okay, wonderful. Okay, all right.
Perfect. Well, welcome. Thank you so much. I am very excited to be joining you. I know it is late for you and very early for me. So I am going to shift gears a tiny little bit because I was once a researcher, but now spend all of my time trying to translate implementation science to make it really accessible. And I am going to try a little bit of interactivity that may or may not work. We're going to see if it's possible in this context. So my presentation actually will bridge beautifully from the previous two, which I hadn't seen before. And so I'm going to go over a little bit of a welcome activity. I'm going to talk about implementation pathways, and then hopefully try an activity about parts of the pathways. Then I'll talk a bit about barriers and facilitators to change at the individual level and a tool we can use to map those. And then I'll talk about selecting change strategies, which is literally how this entire session started, and wrap it up with a couple of resources to support people who are supporting implementation, and end with a Q&A. So I already had a lovely introduction. So essentially, I was once a researcher, but now spend all of my time doing this. So I don't know how much you've heard about this, but if you read the literature on implementation science, there's this kind of new recognition that implementation science was designed to support people to actually get research evidence into practice. And they created this science to make that happen. But now there's a feeling that maybe we're not doing a great job of translating implementation science into practice so that people can actually use it. And we are hearing that there are researchers out there, there are people in government organizations, policymakers, there are people in the healthcare system, there are people in social services, nonprofits, who want to use what we learn from implementation science in their own practice, in the way that they're doing research, and that's not really accessible. And so what we do is we try to translate implementation science for people who want to use it. And so sometimes that's practitioners, and sometimes that is researchers. And a huge thanks, Carrie from our team just posted a link in the chat that has a link to the workbook for this and all of the images. And so you are welcome to go and use any of those images if you would like to use them in your work. And so we are essentially a Canadian organization, but we work very internationally, and I'm super excited because in fact, Asia is the place that we have the least participants in things like our free mini course. So I'm very, very excited to be seeing lots of interest in Hong Kong, and it sounds like multiple Asian countries. So that is wonderful. So I'm going to try something, fingers crossed this works. So I'm going to see if you are open to trying, we're going to see if it works, the Zoom annotation tool. So I know some things are disabled, so I'm not sure if this will work, but we will try it. So it should say at the top of your screen, you are viewing Julia Moore's screen. And it should say view options beside that. And then it should say annotate. And if you click annotate, then this bar should show up. And I want you to click the stamp tool and try to stamp on the screen. Okay, I got one. Okay, another check mark, any stamp. So it is anonymous. No one can see which stamp you put. No one can tell who did it. So lots of check marks. You can pick any stamp you would like. Don't use the spotlight tool. Use a stamp tool is best. If you cannot do this, you can always type answers in the chat, but I like it when it's anonymous so no one can see who is typing. All right. So there's instructions in the chat if you are having any problems. If you are on a phone or a tablet, it will not work, unfortunately. So I will clear all of these and take us to, clear this. First, a fun activity. And then we will have a couple more implementation science ones. If you could go anywhere in the world right now to visit, where would you like to visit? So take that stamp tool and place a stamp. Perfect. South America, beautiful heart. Oh, perhaps South Africa. Excellent. Japan. People showing up a few places around the world. Excellent. Canada, Greenland, ooh, the North Pole, fabulous. Lots of Australia, Europe. Excellent. We are going to use the annotate tool a couple of times today. So leave that open, but don't stamp while I am presenting if possible. So I'm going to clear all of these and get started by talking to you about pathways. So what we've done is we've tried to take what implementation scientists have given us and turned it into something that's a little bit more practical and a little bit more relevant. And to do that, we have what we call 3 implementation pathways that really pull together many different theories, models, and frameworks into kind of a simplified image that we then tease apart depending on how ready people are to actually delve into that level of detail. The first pathway, actually per Nilsen, set us up beautifully because he was talking about power dynamics that exist between people. And then we just had this presentation by Jeanette talking about working with people across the system. Lots of times we don't think about or recognize the importance of relationships in implementing any kind of change, but these are in fact essential to all implementation work. So we like to start with this pathway. This pathway highlights how we need to often convene people by bringing them together. Then we need to do exactly what Jeanette was talking about. Figure out how are we partnering with them? What is their level of involvement? How are we engaging with people? What does that look like? Do we have a governance structure? Who is making decisions? Is that transparent? How are those decisions being made? How will we work together as a team? And if you're implementing something like the first presentation where they're making a change across the entire system, how are you working with people across the system? That's our first pathway. And I'm actually not going to go into it in detail, but that's a first pathway. We delve into this in a lot of detail, thinking about things like power and trust, which are huge factors in implementation. The second pathway is kind of like a meta pathway. It pulls together, in fact, the implementation mapping process model that was presented in the first presentation today, plus some others, and kind of simplifies them. This is the pathway I'm going to talk about the most today, and it highlights how when you go to implement a thing, whether you are want to be an implementation scientist, whether you are a researcher, or whether you are a policymaker or on the ground implementing things, it is helpful to start by exploring the thing you're trying to implement. That means having a team, understanding the needs and gaps, defining the goals that you hope to achieve, and selecting the thing you want to implement. So maybe that thing is a new policy about when physiotherapists need a referral or not. Once we do that, it's so important to define who is being asked to do something differently and what exactly are they being asked to do. People often skip this step, but it is essential to actually enacting any change. Then we can use all those different methods we heard about today to collect barriers and facilitators. So just because we want doctors to refer patients differently or patients to go directly to physiotherapists without getting a referral doesn't mean they will. So when we can understand people's barriers and facilitators, we can use that to select those implementation strategies that people are using. I want to flag that underneath all of this is the importance of relationships. You literally can't do any of these things if we don't first build relationships with people. I'm going to talk more about this pathway and show you a tool that you can use for this pathway. I also want to flag that here I live in Canada, and here in Canada, we've had a lot of discussion about how it is really important to incorporate equity into the work that we're doing. And so we've spent a couple of years really thinking about how can we consider equity in every single step of the implementation pathways. And so we actually just did an event a couple of weeks ago where we released new questions that we can ask ourselves about equity at every stage of the way. And those questions can be found at this website link right here. And so you can go through and look at all the equity questions. And so we're doing a lot of work thinking about how can we make sure that when we implement, We're thinking about representation and participation and self-determination, power, inclusion, fairness, compassion. And so what does that really look like to do? Our third pathway, the last one that we aren't going to go into detail today, but I just want to flag, is that once people have actually built their thing that's ready to be implemented, whether you use the strategies pathway or implementation mapping, there's a whole other set of activities that need to happen. We now need to go and actually plan to implement that. That involves identifying people in the system, what their roles are, assessing and addressing readiness and context. Are organizations ready? What does that look like? Are there contextual factors we need to consider? And do we need to make adaptations to address those contextual factors? Do we have a plan for implementation? Do we have a plan for sustainability? How are we going to make sure we know that what we're doing is actually working? Will we do pulse checks to hear how things are going? And let's make sure we evaluate what we've done at the end. So I'm going to do another really quick annotation activity for the different parts of the pathway. So in fact, it's so beautiful because this pathway was essentially presented in the first presentation using implementation mapping, but conceptually it's the same idea. So could you pull out your annotation tool and put a check mark beside steps that you think are a strength or something that you have experience with and you feel comfortable with? And maybe a question mark for things that you would love to learn more about or think might be an opportunity for growth. Fabulous. So I'm seeing a bunch of check marks in the earlier stages, which is pretty common because these are things that we're often pretty comfortable with as researchers. And if you've gone into the implementation science literature, a lot of people are talking about assessing barriers and facilitators. But I'm seeing a lot of question marks, and maybe even a little bit of love in this last category about selecting strategies, which is excellent because I am literally going to get us there in just a moment. I'm going to skip us actually into here. So talking about barriers and facilitators to change. So when we start thinking about implementing, it is so important to start understanding and thinking about the barriers and facilitators to change. This is all part of the strategies pathway. And essentially, remember I said that once you pick the thing you're going to implement, maybe you have a new policy that you're rolling in. The next step is really clearly defining who is being asked to change and what are they being asked to do differently. Sometimes there are a lot more who's than we would first expect. I was just working with a group that is scaling up an intervention in surgery. And so the goal is to change the protocols for people who are having surgery. And one of the changes is that people are allowed to eat and drink the night before surgery, which didn't used to be the case. When they were doing this initiative, the doctors were on board, the surgeons were on board, the nurses were on board, everyone seemed on board. And they were having patients who were still coming in the morning and they would say things like, oh, I haven't had anything to eat or drink since last night. And they couldn't figure out what is happening. And they finally realized that there was someone, an administrator, who was calling the night before to remind the patient that they have an appointment at 8 o'clock in the morning. And they would say, and make sure that you don't eat or drink anything when you come in. And that was the last person the patient was talking to. And so even though it's not a clinician, that person was driving the patient's behavior, and they had not included that person in the number of who's that they needed when they rolled out the program. So it's a great example of sometimes there's little who's that are really important for our work. Then we want to understand what is it that we want them to do differently. And then just because we want them to do that thing does not mean they're going to do it. And so we want to understand their barriers and facilitators to change so that we can pick change strategies or implementation strategies that directly address those barriers. And we want to do that using behavior change theory. If we don't do this process, people tend to pick the change strategies they know and are comfortable with things like training. And so people revert to training even when that's not necessarily the best strategy to address the barriers that people have. You will encounter barriers at the individual level, at the team level, at the organization level, and at the system level. I'm going to focus today on individual and team level barriers, and we would use a different framework to think about organizational or system barriers. In fact, it looks like you've heard several times about the Consolidated Framework for Implementation Research, the CFIR, and that's one of the frameworks that's used to capture organization level barriers very often. It's also so important to remember there are not only barriers, but there are also facilitators. It is so easy to focus only on the bad things, but there are lots of things that actually make implementation easier. And so don't forget about facilitators. So in order to link these together, we want to use behavior change theory. If you have a background and experience using behavior change theory, then I highly recommend you use the behavior change theory that you are comfortable with and that you know and that works well for the work that you're doing. If you are brand new to behavior change theory, which many of the people that we train and support are new and kind of don't really use behavior change theory very often, I tell them that there's a theory that we can use that's very simple and very accessible. That means that anyone can use behavior change theory when picking strategies. That theory is called the COM-B. And it says that in order for a person to change, 3 things need to be happening. They need to be capable of change, they need the opportunity to change, and they need to be motivated to change. Our experience is people love capability building. We love training people and giving them education and new materials. There's more discussion about opportunity, how we can create environments that support change, and a lot less work happening on how to motivate people. What I like about the COM-B is that A, it's super simple. So if you have a more complex behavior change theory, again, keep using it. But if you are new, this is really easy for people to use. And there's this framework that teases apart what each of those components kind of mean. So under capability building, we can see that in fact, it's made up of 4 things. Do people have the knowledge about what they're being asked to do? Do they have the skills to do the thing they're being asked to do? Do they remember to do the thing they're being asked to do? Or is it a habitual behavior? So something that we do without even consciously, cognitively thinking about doing it. And to change those habits, we actually kind of have to do a different thing than some of the other things that we typically do. Down here, we have opportunity, which is really made up of 2 things, but they're kind of huge buckets. One of them is social influences. So are we being influenced by our peers, by managers, by leaders, by opinion leaders? And then there's this bucket, environmental context and resources, which is kind of a catch-all bucket where we throw lots of stuff into that. I put it in a parking lot, and then we take it all apart using a different framework, like the Consolidated Framework for Implementation Research. But what I like about this theory is that it helps us unpack motivation, which is the thing that we're often not great at doing when we're supporting change. So it highlights that people might be motivated or lack motivation. For example, maybe they have a confidence issue. They are not confident that they can do the new thing they're being asked to do. That can be a huge barrier to trying to do something new. Sometimes people don't see it as their professional role or their identity. Sometimes people are worried that if they do this new thing, some bad thing is going to happen. So let's take the example of the physiotherapists. They might be worried if patients self-refer to a physiotherapist, they're going to have a missed diagnosis and a bad thing might happen. So that would be an example of a belief about consequence barrier. They're worried this bad thing is going to happen. And if you noticed, I used the word worried, which is in fact an emotion. We often would like to think that we make all of our decisions very, very consciously and cognitively, but emotions drive a lot of what people do. And so understanding people's emotions and their emotional barriers is really important. Goals and intentions are kind of two sides of the same coin. So I might say, I want to work out later today. That's a goal. I plan to work out at 6 p.m. after I eat dinner is an intention. This is important because intentions actually show a little bit increase of likelihood someone will actually do it. Our behavior might be reinforced. So something we're doing might be reinforcing the current behavior or maybe the new behavior. And some people just have that general optimism or pessimism about new things. So kind of people like roll their eyes, oh, not another new thing, right? So it's a general pessimism. So from there, I'm going to do a quick little mapping activity, again, with your annotation tools. So I'm going to give you 3 different barriers that actually 2 of them happen to work very well for the previous example. But the first one is probably one of the most common barriers we hear from people. So people might say, so you might say, hey, we have this new change we're rolling out in the hospital. And someone says, it's not my job to do this. Can you pull out your stamp and stamp on, perfect, people have started. Which of these different categories of the theoretical domains framework do you think that relates to? Fabulous. So this is related to social and professional role and identity. Amazing. All right, my second example. Once I made the change, I was surprised at how well things went. When I was hearing about the physiotherapist example, I could see this coming up as a facilitator. It's not a barrier, it's a facilitator. So what kind of facilitator is this? Yes, excellent. So this is a reinforcement facilitator. So once they've made the change, good things are happening, and that reinforces that behavior. Okay, I am worried that making this change will negatively impact my patients or my clients. What kind of barrier is this? Excellent. This is beliefs about consequences, and it technically maps to 2 different things because it says I'm worried. So I would also map this to emotions. So sometimes we map things to more than one place. One thing that I find, my experience is researchers get very hung up on having perfect mapping, and they get very, very stuck sometimes. And I tell people, do not worry about getting stuck with perfect mapping. Have a discussion with your team, get to a close enough mapping, because I will show you in a second how it kind of does, like perfect mapping doesn't matter as much as you would think. And I'm going to show you why. So why do we do all of this? We are doing this in order to select those implementation strategies that people use. Notice I use the word change strategies because we're trying to translate everything so that it is much more accessible to people. And we found that term means more to people in the field. But you can use implementation strategies if you were like staying in the implementation science field, because that's what they're called in the literature. So what's using the COM-B and TDF links out directly to something called intervention functions. Intervention functions describe the underlying function that your change strategy is going to serve. So I'm going to repeat that because this is the most important thing I'm probably going to say in all of today. The intervention function describes the underlying function or purpose that your implementation or change strategy is going to serve. So you might realize you need to educate people. And so it is going to have the function of educating people. That's about building knowledge. Education and training are often paired together, technically not the same thing, but often paired together. Training is about building people's skills. You might have the function of modeling what the behavior looks like. So showing people, hey, look, this is what it looks like to do this behavior really well. Maybe you need the function of persuading people, of convincing them that this is a good change to make. Maybe you have the function of incentivizing them, so giving them some kind of reward. Maybe you're trying to enable them to change. This is about removing barriers that make it hard to change. Maybe you have the function of restructuring the environment. And sometimes we have the function of restricting people from doing stuff. That doesn't happen often, but occasionally happens. And so what's really cool is these researchers in the UK took the COM-B and the theoretical domains framework and mapped it out to all of these different functions. And so they say, oh, look, if you have a knowledge barrier, then you need to educate people. If people have an emotion barrier, you can see that education and training, our favorite strategies, aren't going to work. We need to do things like modeling and persuading to support people to change. So now I'm going to show you a tool that you can use to help pick change strategies. So you can go to this QR code if you would like, or, oh, perfect. Carrie just posted the link in the chat. I'm going to stop sharing and start sharing again so that hopefully you can see. Share and hold on, tell me if, okay. Are you looking at the strategies tool on the website? Or are you looking at a slide? Yep, good, okay. So this is the page that Carrie put that link. It should take you to. Scroll down to this part of the page. It sometimes appears white when you first appear. And you can go in and click through this. I'm going to show you how to use it really quickly. It is free. Anyone can use it. Anyone can use it with their teams. And it takes you to exactly this place. So it assumes you have done the work of picking your barriers and facilitators. And then it says, okay, go in here. And you could say, ooh, I'm seeing barriers that are related to beliefs about consequences, right? That was an example from earlier this morning. And it says to change those kinds of barriers, we might want to educate, model, or persuade. Then what we did is we took that list of ERIC implementation strategies plus strategies from a few other places and inserted them into here so that you can see selecting change strategies to address beliefs about consequences, which is of the function of persuading, and here are possible strategies you can use. All of these strategies are not going to be the right fit. You need to talk to your team, figure out what works, right? So maybe champions and identifying early adopters might be a great fit, but maybe mass media and public demand are not the right fit for what you're working on. So this is not the answer. It's the start of a conversation to say which of these things would help us. You can go through here and then say, oh, we've picked some different strategies that help us with persuading. What other kinds of barriers can it help with? Oh, look, it can help with all of these. That's why sometimes it doesn't matter quite as much if you don't get the exact perfect mapping, because if you're debating between beliefs about consequences and emotions, they end up mapping to pretty similar things. So you can sometimes flip it around. So I am going to hopefully return to sharing my slides. All right, do you see my slides, number 4?
Yeah.
Yes, perfect. So I am just going to wrap up with a couple of other things and resources. So that is a tool that anyone can use to help you select change strategies. And because our whole goal is to synthesize and translate implementation science for people who want to use it, we have lots of other things that people are using. We have a newsletter that shares new articles, new resources that people have and people are using in the field. We also have a toolbox that has lots of different tools, images that people are using that can help you kind of expand and explore what's happening in implementation science from a really practical perspective. If you want to introduce implementation science in a small, digestible way to your teams, I would recommend Inspiring Change 2.0. It takes about an hour and a half to complete. It's totally free. We have had, I think, 8,000 people from over 100 countries take it. So it's like a really easy, super short way to introduce people to implementation science. And if you want to connect with other implementers, we have the Implementing Change community as well. All the things I presented, or most of the things I presented today, are from this course that we have called the Strategies, the How of Creating Sustainable Change, which really goes through in detail how to go through that whole process. And it is part of what we call our level 1 certificate. So there's 2 groups now that have implementation support specialist certificates. This is not to be a researcher and a scientist. It is for people who want to use implementation science to actually support the changes that they're making. So it's not, we have many researchers, but not to become an implementation researcher, because there's lots of certificates out specific to that. And with that, what sounds like you can't unmute yourself, but I open it up to lots of questions, and want to wrap by saying a huge thank you to everyone. Here's our different contacts. You can reach out, find lots of information about us. And so it is lovely to connect with all of you. And thank you for annotating. I wasn't sure how it would work, but it worked well and we were able to use it. So yeah, so I open it up to any questions.
Thank you very much. Thank you, Julia. Thanks for the interactive way of presenting. This is really fun. You know, you can use the annotations to give immediate response anonymously.
I think, yeah, I agree. This is really a good way, very pedagogical way of showing the behavior change wheel, how it's combined and how it's combined with strategies, which is what Professor Yeoh is also doing in their project. And I also like actually that you call it change, implementing change strategies, because implementation science is all about change. And I think if you recognize that change is often quite difficult, I think it gives an explanation for why we need to support implementation. It does not happen by itself. People are, I mean, status quo is our safety zone and comfort zone. So change might require quite a bit of support strategies. So I totally agree with that. Do we have any? So we have a question, Eliza, is COM-B part of behavior change wheel model?
Yes. So yeah, exactly. The COM-B is it's part of the behavior change wheel model. And in fact, the people, Susan Meeke and her colleagues who developed the COM-B and behavior change wheel, they have mapped COM-B to TDF to what they call behavior change techniques. And those behavior change techniques are more micro level changes like a clinician would do with a patient. So say you were a clinician or a counselor or a therapist, you might use this strategy when talking to a patient. So it's things like action planning and finding social supports. Our experience is in implementation science, we're normally looking for strategies that we can use within a department, within a unit, within an organization. And so what we did is we mapped the COM-B and TDF to this higher level of strategy, things like champions, communities of practice, and different strategies at that level rather than the individual level. But exactly, COM-B is exactly part of that behavior change wheel model.
I think they call it a behavior system or something. It's really a system of different components where COM-B and TDF are two. I also think you commented that you could say that COM-B and it's from a psychological viewpoint in that there's only sort of two, the opportunity or context or the social surroundings, but then you can combine COM-B and TDF with Zephyr, because Zephyr opens up for more of the external or the social influences, but it's not as detailed as TDF or COM-B. Well, what's your thoughts on that, combining?
Yeah, so we combine them all the time, like very, very often. And in fact, we use the TDF and COM-B to help us design the thing we're going to implement. And then we use the consolidated framework for implementation research to help us understand the context and the readiness so that we can make adaptations to that context. So we typically like use the TDF and the COM-B at the beginning to design what we're implementing, and then use the Zephyr when we're looking at different sites and understanding contextual factors at each of the different sites. We, at the same time, I both really like CIFAR 2.0. There's a new version, but our experience is that it is not as detailed and it is missing many system level factors. And we do a lot of work globally where system level factors are very, very, very important. And so we have been in the process of trying to build a tool that looks just like that strategies tool I showed you, but using what was originally going to be the CIFAR. But we have expanded it to include more factors, especially at the system level, because we think that that's really important. And in fact, we used one of your reviews of different papers, and we pulled in, we mapped 13 different frameworks and pulled in additional factors that don't exist in the CIFAR. And so we're pulling that together and we're mapping it out to strategies, but it is very complicated, more complicated than the individual level. So we're at a beta testing, but it is a little bit stalled because it is not simple.
I think tomorrow it ties in with tomorrow Sarah Birkin is going to talk about organizational theory, which is, I guess, increasingly important, the recognition that it's often at a collective or a team or a professional group level.
Exactly.
Do we have any more? I'm amazed that we have so many participants, and even though it's quite late here,
Yeah.
not used. I mean, it's 8:30 here p.m. So I'm impressed by the interests.
Great. So thank you very much, everyone, for joining the second seminar. And especially thank you, Professor Yeoh, Jeanette, and so Julia for delivering 3 very interesting seminar on this important topic, and also Pierre for being the moderator. So see you tomorrow at the same time, of which we will have 2 lectures on the concepts and theories of potential utility in implementation science, featuring Professor Pierre Nilsen and again, Professor Sarah Birkin. So see you at the same time tomorrow. Thank you very much for coming. Bye-bye.